welcome to The Code Tray, the podcast of the ACCP Emergency Medicine PRN. I'm your host, Christian Kroll, an emergency medicine and ICU pharmacist at the University of Iowa Hospital and Clinics. To view this recorded presentation, head to our YouTube channel at youtube.com/@ACCP EMED-PRN. And for PRN members, slides can be found under the Libraries Entries section of the ACCP Communities website.
Hi everyone, my name is Samar Ashrafi and I am the current PGY2 Emergency Medicine Pharmacy resident here at Advocate Christ Medical Center. And today I will be talking to you about the role of pretreatment IV calcium in reducing diltiazem-related hypotension in patients with atrial fibrillation. Now going into a little bit of background information. Atrial fibrillation is one of the most commonly treated arrhythmias in the emergency department, presenting as an irregular rhythm that is neurocomplex and does not have any distinguishable P waves. It can be caused by a multitude of factors such as age, coronary artery disease, ischemia, or hypertension. And patients with atrial fibrillation will often present to the ED in rapid ventricular response, or RVR, which is defined as a heart rate of greater than 120 beats per minute. Now, patients that are in RVR for a prolonged amount of time can see an increased myocardial oxygen demand that can ultimately lead to myocardial ischemia and heart failure. So it's important that when patients are presenting in this state that we are treating them in a timely manner. Now, in order to treat them, there are a couple of different options that are available. So most commonly, we'll use beta blockers such as metoprolol or calcium channel blockers such as diltiazem or verapamil. Now, the way that all of these agents work is by serving as AV nodal blockers by their own unique mechanisms. So metoprolol will block the beta-1 receptors and slow the conduction through the AV node, versus the calcium channel blockers will inhibit calcium from entering the slow channels in the myocardium during that depolarization phase. Now, ultimately, the AV node will then take longer than normal to recover from an electrical impulse, therefore blocking many of that rapid atrial signals and preventing the ventricles from contracting as often, which is going to lead to that decreased heart rate effect that we want. Now, the dosing for these different medications are listed there. Metoprolol is typically given as 5 milligrams IV for 3 doses as needed. It has been studied in higher doses, up to 10 milligrams in a couple of studies, but most commonly everyone is doing 5 milligrams. And then for diltiazem and verapamil, both of those are weight-based with sequential up titrations in the dose as needed. Now, the onset of all of these medications are typically 2 to 3 minutes with a half-life of a few hours, just to make sure it really works. And then side effects include, most importantly, avoiding this in patients with cardiogenic shock, because we ultimately don't want to do anything to worsen that compensatory mechanism in these patients. And with calcium channel blockers specifically, hypotension is one of the most common side effects, which is ultimately why verapamil is not really chosen due to the large degree of hypotension that can occur, and diltiazem is the favored calcium channel blocker in these patients. The 2023 AHA guidelines actually recommend using either non-dihydropyridine calcium channel blockers, so either DILT or verapamil, or beta blockers, providing that EF is greater than 40%. So they don't give a specific indication or patient population that would be beneficial for one or the other. Digging more into the mechanism of calcium channel blockers, I mentioned that they inhibit the calcium influx into the myocardium, which will slow that AV node conduction time and prolong the refractory period, also contributing to that negative inotropic effects that we want, which is going to help decrease that heart rate. But not only does it inhibit the calcium influx in the myocardium, but it also inhibits it into the vascular smooth muscle. That causes peripheral vasodilation, coronary vasodilation as well. So this plus that negative inotropic effects that we see will ultimately lead to that decreased blood pressure and hypotension that we're seeing in these patients. So there's this thought that was, what if we gave patients calcium beforehand in order to really saturate those calcium receptors in the periphery and allow for calcium to solely work in the myocardium, and you're not providing that added effect of hypotension that could occur. There are a few studies that have looked at this, specifically dating all the way back to the 80s. Which would include the first trial in 1983 by Weiss and colleagues that looked at the use of IV calcium gluconate before verapamil, and they actually included patients in 2 different groups where they either got the calcium after the verapamil, so that was group 1, or in group 2 where they got calcium before verapamil. And you can see that the dosing of calcium was 90 milligrams elemental, which is important to note because some studies that came after this did have some misinterpretations of the exact milligram amount that was used because it was not clearly defined if it was 90 milligrams of calcium gluconate or 90 milligrams of elemental calcium. And that can lead to a little bit of confusion when you're designing this trial. However, you can see in the outcomes that the first group did have an increase in systolic blood pressures with calcium from 99 to 126 millimeters of mercury. And then in group 2, they also increased systolics from 99 to 112 millimeters of mercury. So overall, there was the added benefit of preventing hypotension and actually increasing that systolic, and overall did not also interfere with any antiarrhythmic properties as well. So this trial, which was the first one that was done, showed that calcium was effective at both restoring and preventing that drop in systolic blood pressure in patients that were treated with IV verapamil 5 milligrams.
So in 1986, Haft and colleagues decided to also look at the role of calcium before verapamil, and they had a placebo arm where these patients just got verapamil, either 2.5 to 5 milligrams IV push, or they got 1 gram of calcium chloride, so 270 milligrams of elemental before getting the calcium channel blocker. And in this trial, they included patients that were in RVR, but that was defined as heart rates greater than 140, or if they were in SVT. For outcomes, they looked at that systolic blood pressure reduction, and they found that the verapamil only group had a drop in systolics by about 20 millimeters of mercury. But in the calcium group, they actually increased to about 2 millimeters of mercury, and that was statistically significant. They did not find any difference in rate control between the two groups as well. It was about an average drop of 55 beats per minute from baseline. So this theory builds upon the previous trial that was published. And then the last study that looked at calcium before verapamil was in 1992. This was a retrospective chart review that included patients with AFib, aflutter, and SVT as well. And this is where that differing calcium dose comes into play. They had interpreted the original 1983 study to mean 90 milligrams of calcium gluconate and not elemental. So these patients actually got substantially lower doses of elemental calcium. So anywhere between 9 milligrams elemental to 27 milligrams. And that was dependent on if they either got calcium gluconate or calcium chloride. The trial authors didn't publish exactly how many patients got which salt formulation. And then the other group they had was just patients that were treated with verapamil only. So they found that 5% of the patients that only got verapamil became hypotensive, but among the 18 patients that got calcium, none of them had any experiences of hypotension. And then the median decrease in systolic was about 4 millimeters of mercury in the calcium group versus increase in systolic. And then in the verapamil only group, they actually found a decrease by 5. And overall, again, no difference in antiarrhythmic efficacy in either group. So all of these trials support the idea that giving calcium before verapamil seems to have a benefit of preventing any hypotension that can occur. And that's typically the reason why we're not reaching for verapamil so often in patients that present to our ED and RVR, just because we know that the risk of hypotension is so large with that one compared to diltiazem. However, could we still use calcium before diltiazem? And what are the effects that can occur? So the first trial that actually looked at calcium chloride before DILT was in 2004 by Kroll and colleagues. This was a prospective randomized double-blind trial that was done in San Antonio, where they wanted to again study calcium before DILT this time. They copied the same elemental dosing of calcium as done in the 1983 trial. So 90 milligrams elemental given before diltiazem as the standard IV push dose versus placebo before the diltiazem. And their null hypothesis was that pretreatment of calcium would not affect blood pressure due to DILT. And they included patients that were AFib or aflutter and that in RVR, which was a heart rate greater than 120. Patients were able to get repeat doses of diltiazem at the 0.35 mg per kilo if needed. For outcomes, they found that there was no significant difference in systolic blood pressure drop between the two groups. So you can see that with the patients that got calcium, they dropped by about 8 millimeters of mercury versus in the placebo arm, it dropped by about 14, which wasn't statistically significant. It could be clinically significant depending on what the patient's baseline systolic was before treatment. And overall, both groups had statistically significant decrease in heart rate, so their rate control was not affected at all by giving calcium or not giving it. So they concluded that pretreatment did not reduce the incidence of hypotension that was caused by diltiazem. And then the last study was done in 2023, where it was a multi-center retrospective cohort study from January 2013 to February 2022. Was again looking at the role of calcium before DILT, but this study they were allowed to include patients that got DILT either 60 minutes or got calcium either 60 minutes before diltiazem or up to 30 minutes afterwards. But majority of these patients did get the calcium before the antiarrhythmic was given. So they had two groups, about 200 patients get standard diltiazem versus about 56 get the elemental calcium. And because this was retrospective, they had to look at which salt formulation that patients got, and majority of them got calcium gluconate. Then the remaining 10% got calcium chloride, and it averaged out to about 93 milligrams of elemental calcium, which matches like the previous trials that have studied this. And their outcome was a change in systolic blood pressure at 60 minutes after diltiazem, and they found that the reduction was pretty similar between the both groups, so -2 in the monotherapy versus a drop in a 1.5 in the combination. They also had a subgroup analysis of patients that got calcium before the diltiazem and ultimately found that there was no difference at all in the reduction in systolics. And the incidence of hypotension as well was a little bit higher uniquely in the combination group. But at baseline, the patients that got calcium had lower systolics at 109 versus 122 in the diltiazem monotherapy. So, practitioners in that trial in that arm were probably just more inherently biased to give lower doses of diltiazem. Those patients typically got 10 milligrams of DILT versus 15 in the monotherapy group. So a couple of other factors that could have played a role into that finding of hypotension. But overall, ultimately, they found that using calcium did not change the systolic blood pressure that occurred following IV diltiazem administration. Now, all of these trials looked at somewhere around 90 milligrams of elemental calcium. Of course, we had the one that looked at 27 and then the one that looked at 270, but across the board, you can see that either calcium led to an increase in systolics or a lower decrease compared to placebo. So that's kind of brings me into the trial that I'm going to be talking about today, which is published in American Journal of Emergency Medicine in December, which is looking at the role of calcium before DILT. So this was a prospective cohort, single center randomized double-blind trial done in Turkey that included enrolled patients from January of 2023 to June of 2024. And included patients that were over the age of 18, had an EKG confirmed with AFib or A-flutter, heart rate greater than 120, and then systolic greater than 90. And they excluded any patients that were either hemodynamically unstable, history of sick sinus syndrome, Wolff Parkinson's White, or concurrent use of any other oral or IV rate control agents, whether that be beta blockers, amio, digoxin. So their primary outcome was change in systolic blood pressure at 5, 10, and 15 minutes following diltiazem administration. And then their secondary outcomes included change in heart rate, as well as need for additional doses of DILT. And then safety outcomes included hypotension, so systolic less than 90, and then any hypercalcemia that occurred. For the intervention, patients were randomized to get either 90 milligrams or 180 milligrams of elemental calcium, but using the calcium chloride formulation, or they got placebo, and then all of them were then randomized to get, were followed with diltiazem at the standard 0.25 milligram per kilo push at the max of 25 milligrams. And then just of note, calcium chloride, 1 gram of it has 270 milligrams of elemental calcium versus a gram of calcium gluconate that has 90 milligrams. So in terms of volume that was used for the study, if the patients got 90 milligrams, they were getting 3.3 mLs roughly of the intervention versus 6.6 if they were getting the 180 milligrams. They wanted to enroll at least a minimum of 210 patients to detect a difference in systolic and heart rates with 95% power. So they enrolled about 421, but a lot of them were excluded either because they declined to participate in the study. They were using other rate control agents, and a handful of them actually spontaneously got rate control after getting pretreatment. So those were all excluded from the final analysis, and they ended up with 217 patients that were left. So they had about an average age of like 63 in all three arms. Most of these patients were chronic AFib or A-flutter. And then of note, the heart rate was about like 155 to 160 at baseline, and then the systolics were about 130 to 133 among all three groups. So looking at their results, you can see that the first column here, which is the change in heart rate at 5 minutes from baseline amongst all three interventions, did have a significant reduction across all three pretreatment groups, as well as all three time points. So at the 5, 10, and 15-minute mark, the biggest drop was, of course, in the placebo group with a decrease in about 60 beats per minute, and then it just substantially decreases to about 50, depending on if patients got 180 milligrams, and that's carried on across all three time points as well. And then if you look at the drop in systolic, the placebo group had a drop at about 15 millimeters of mercury that stayed consistent from the 5-minute to the 15-minute mark. And then calcium 90 milligrams had about a drop in 8 to 9 across the 15 minutes. And then 180 milligrams actually did not have any effect on systolics. And at the 15-minute mark, they dropped at about 1. And then none of those were statistically significant. So you could see that maybe like giving higher doses of calcium could help with preventing any hypotension from occurring or any drop in systolics. This is just a graphical example of the comparison in heart rate. So at the 5-minute mark, all three arms had a significant reduction and achieved adequate rate control for these patients, and that stayed consistent across the three time points. And then looking at the systolic blood pressure at the 5-minute mark, the placebo had the most rapid decrease. So it fell to about 117 millimeters of mercury. And then the 90 milligram arm had about 124 millimeters of mercury at 5 minutes. And then the 180 milligram group stayed pretty even across at 129. So one of the strengths of the study, of course, is a prospective trial with a really large sample size. So just like 217 patients that they were able to enroll, which is larger than the previous studies that were talked about. Their methodology as well is pretty simple to follow because they gave the calcium over 2 minutes right before the Diltiazem, and patients were able to get any subsequent doses of Dilt as needed. Some of the limitations, however, is that they only collected data up until the 15-minute mark. So in terms of what these patients were getting after that, so if they got repeat doses, they reported that 26 patients got second doses, but no information on what their vitals were, if they ended up getting additional therapies like a drip or a differing agents that were used for rate control. And they also didn't comment on any other therapies that could have been used for AFib. So patients got magnesium subsequently as well. We, just unfortunately don't have that information. And their calcium dose, I appreciate that they wanted to go beyond the 90 milligrams that's been routinely studied and look at if higher dosing would have a benefit. And, from the results of the study, obviously we can see that 180 milligrams kept like a sustained systolic blood pressure of about 130 and didn't drop it at all. But it's just unknown if we can go beyond that. And the previous trials that have looked at 270 milligrams before verapamil did also find that there could be a benefit as well. And then, of course, the study was done in Turkey, so applying their patient population and that validity to our population here in the US might be a little bit more difficult. So overall, they concluded that giving calcium effectively prevents Diltiazem-induced hypotension in these patients without compromising the efficacy of achieving rate control, which is, of course, the biggest thing we want to achieve, but also not compromise at the expense of giving this additional agent. And then one additional thing that I just wanted to point out is that there's a lot of new current trials that are enrolling for calcium before Diltiazem. And one of them was actually done here at Advocate Christ over the past year. We looked at giving 1 gram of calcium gluconate instead, which was 90 milligrams of elemental as well. And we gave that over 5 minutes, and then patients were subsequently getting Diltiazem as the standard weight-based push afterwards. So we enrolled about 46 patients in each arm, and we were looking at their primary outcome, which is a mean difference in systolic blood pressure at the 5 and 15-minute mark after the bolus. And then the secondary outcomes included any change in rhythm, mean change in heart rate, or adverse effects from either the calcium or the Diltiazem. Our results and our stats are still pending. The trial was just actually finished enrollment not too long ago, but it just continued to point out that there are still trials. This is, of course, the one that I just discussed came out in December, and there's further studies that are looking at possibly differing doses of calcium as well.
If you have enjoyed this presentation content and would like to hear more, subscribe via your favorite podcasting app. Additionally, make sure to check out our YouTube page for all recorded presentations. Thank you for listening to this week's ACCP Emergency Medicine Journal Club presentation. Join us weekly for review and discussion of new journal articles in emergency medicine. This podcast provides general information only and does not offer individualized medical or professional healthcare services, including pharmaceutical advice. The contents and materials in the podcast are not intended to be a substitute for inpatient pharmaceutical advice, diagnosis, or treatment. And the use of the contents and materials in the podcast does not constitute a pharmacist-patient relationship. As a result, the information in and materials linked to this podcast are applied at the user or patient's own risk. Users or patients should consult their physician or personal healthcare professional. The user or patient should not ignore or delay seeking care because of something they heard on this podcast. In case of an emergency, the user or patient should contact their physician, call 911, or go to the nearest medical emergency facility. The views and statements expressed on this podcast are those of the host and guest and should not be interpreted to reflect the official position or policy of ACCP or the Emergency Medicine PRN.